Recording in progress.
Okey, Prof. Samsyah, boleh kita mula?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to everyone. Thank you for attending this morning CPC hosted by the Department of Ophthalmology, Hospital Chancellor Tuanku Muhriz. This morning we are grateful to have a lineup of speakers to talk to us on an interesting case which happened to a 67-year-old man who had poor vision since he was a teenager but only gave problem when he was around 60 years old. So with us we have Dr. Muhammad Ihsan Jamaluddin from the Department of Ophthalmology to present the case, followed by a line of speakers, Associate Professor Dr. Fariza Fazil from Neurosurgery Department, Associate Professor Dr. Shahizun Azura Mukari from the Radiology Department, Dr. Khairia Siddiq from the Oncology Department, as well as a special guest speaker from Hospital Serdang, the Head of Department of the Pathology Department, Dr. Wan Azura Wan Yaakob. I will now call upon Dr. Muhammad Ihsan to present the case. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning. Okay. I bid to Prof. Shams, all the professors, all the panelists, and everyone that joins us this morning. So today I will start with the case presentation and followed by Dr. Liza's and the panelists for the discussion. So I will start to share my screen. Okay, can everybody see the screen?
Yes,
Right.
can see.
Okay, so the journey start with the case report of a 67-year-old Chinese gentleman who has underlying hypertension, dyslipidemia, and ischemic heart disease. He actually complained of right-sided painful blind eye for 2 years. And since December 2018, the pain has progressively more intense. So he has poor vision of the right eye since the age of 15. He is unsure of the cause. He sought medical treatment, and the affected eye he was told that the affected eye has damage, so there is no inactive treatment. So otherwise, he has no acute complaint prior to this episode of pain. So for this presentation, he complained of gradually worsening pain for the past 2 years. So, and it has progressively worsened for the past 3 months, and the pain is associated with redness and tearing, together with headache. Otherwise, he has no nausea or vomiting. The pain has no aggravating factor, and it is occasionally relieved by analgesia. Okay, so he presented to an ophthalmology clinic in Pahang, and he was told to have high intraocular pressure. So they planned for laser transcranial photopsychocoagulation, and the patient was counseled for evisceration. And patient then was referred to us because he requested for second opinion, and it is due to the intolerable pain. Otherwise, he has the sonography done under private cardiologist, and there is no surgical history, there is no drug or food allergies. For his examination, when he presented to us back in 2019, he was alert, conscious, the vital signs are normal. The vision of the right eye was no perception to light, and the left eye was 618 with pinhole of 612. So on the examination of the eye, the right eye is already tight-skulled. There is injection of the conjunctiva with swelling at the superior temporal and nasal area. And the cornea was opaque with poorly visible iris details. He also has thin sclera. So the intraocular pressure during presentation was 90 millimeter mercury. The millimeter mercury, and there is presence of reverse relative examination shows there's early cataract with otherwise normal ocular examination. Ultrasound sonography of the eye. So in our patient, you can see that there is loss of globe contour with no obvious mass to be detected. We can compare with the normal ultrasound that is on the right side. You can see that this is a well-defined globe contour with visible ultrasound of the retina, the optic nerve, the lens and cataract, in comparison to our patient that has already shown loss of the globe contour. So our provisional diagnosis at the time was right painful blind eye with secondary glaucoma and left precious eye with mild cataract. So, okay, and evisceration with orbital implant was done on the 16th of April 2019. So evisceration, as the pictures show here, okay, is where the content of the eye is being removed, okay, but the outer layer of the eye, which is the sclera, is left intact, and we also inserted an implant, okay, to form the eyeball. So unfortunately, during the operation, we noted there's multiple strongly adherent hard fibrotic mass on the inner surface of the sclera shells. Thus, we took an HPE and sent for HPE, sorry. So, okay, it surprised us that the HPE result came back as a right method. This will be discussed further by the panelists. So what we did is we did proceed with the systemic workout, and all the tumor markers came back as negative. We also proceeded with radiological imaging of the whole body, including the thorax, abdomen, pelvis, orbit, and brain. And we can see that there's a well-defined heterogeneous enhancing right intracorneal lesion, as shown as in the picture. Okay, with that arise from the distal part of the right optic nerve and abutting the right superior rectus muscle. The rest of the right optic nerve is bulky and enhancing, and it did not extend intracranially. The lung, abdomen, and both kidneys, however, interestingly, was normal, and there's no focal lesion seen. So there's no CT evidence of primary renal tumor. So we refer the case to the nephro and oncology team, and for ophthalmology, intracorneal tumor on the 1st of October 2019. So exenteration is where we remove the content of the eyeball and the socket, including the muscles, the lacrimal gland, the optic nerve, and the bones of the orbit. So we did a fresh frozen section intra-op, and it shows no malignant cells with clear margin. There is no addition to periosteum, and HPE was again sent. So this is the picture of day 3 of right eye exenteration. All right. So the HPE, as previously suggested renal cell carcinoma, it came back consistent. Sorry. And however, there is optic nerve, the optic nerve margin, there is malignant cells involvement, and they are free of the other surgical margins. So we refer to oncology, and they did radiotherapy of the right orbit area with 50 gray for 25 fractions. So the treatment commenced on 18th of December 2019 and completed on the 24th of January 2020. All right. So when he actually came to us, he had a few appointment or visit to us, and it was actually normal until when he came for the next follow-up in 21st January 2021. He was previously normal. He had no complaint, but on the 21st vision of the left eye has become blurred for the past 1 month. Prior to that, he has left eye cataract operation done under private ophthalmologist 1 week prior to that ocular complaint. So he said that after the surgery, the vision was actually quite okay until 1 week after that, and vision has started to worse. So on ocular examination, we found out that the visual acuity of the left eye was 624, same as pinhole, and the assessment of the anterior and posterior segment were actually normal, with normal intraocular pressure of 15 millimeter mercury. However, the confrontational test done shows there is left temporal visual field loss. So we proceeded with visual field test, and we can see it on the left side of the picture that there is temporal visual field loss of the left eye. It also involves the inferior part of the medial field. And the other picture is the color vision D15 test that we use for color blindness, and it was normal. So we admitted the patient, and we did an MRI on the 25th of January this year, and it shows extraocular mass seen at the base of skull with epicenter, its epicenter at prechiasmatic right optic nerve. So this will again be discussed by the panelists. So for the left eye, it progressed into no perception of light within a few weeks. And we did refer to neurosurgical team for intervention. However, due to the high mortality rate of the tumor being excised, and we referred to oncology team, and they commenced the second cycle of radiotherapy. Okay, that's all for the case presentation.
Thank you, Dr. Ihsan. That is a wrap-up of the whole case. We will listen to all other panelists on the details of what happened to this patient. I will now call upon Dr. Wan Azura Wan Yaakob, our guest speaker from Hospital Serdang, to discuss with us on the histopathology of this said patient.
Assalamualaikum, and thank you very much. Thank you for inviting me. Boleh dengar ke?
Dengar boleh.
Dengar, okay. I'm sorry, okay, about this. Actually, I don't. It was about 2 years ago lah that a few slides were sent to me for a second opinion. So I don't really have the detailed report. If Dr. Osmaliza can just show us is there a slide for the HPE report? Hello?
Dr. Liza?
Dr. Liza, yes.
Can you respond, please?
First, I think we can call other panelists if it's okay.
Yeah, I think you call other panelists because I think mine could be the final one or the.
Okay, all right, that's fine. We listen now from Associate Professor Dr. Shahizun to discuss on the MRI findings.
Okay, thank you very much. Can I share my screen now?
Yes, please.
Dr. Ihsan kena unshare his first. Oh, tak perlu.
Boleh share terus, Doktor. Boleh share terus.
Okay. Alright. Thank you very much to the ophthalmology department for inviting me to contribute and share the images for this patient. So what I'm going to do first is to share with you the CT scan that was done as a staging, part of the staging for this patient. And as you can see here, we can see that there is a mass within the orbital cavity and it's intracorneal in location. And it is mainly affecting the optic nerve. And if you compare it to the contralateral optic nerve, we can see that the optic nerve is actually thickened and it extends just marginally into the intracanalicular part of the optic nerve. This is the coronal image, which is showing the abnormality as well. You can see the mass here. And as we go more posteriorly towards the orbital apex, we can see that the lesion is occupying the orbital apex. And this is where the site of the optic nerve is on coronal. And we can see that there is fullness. But however, we can't really differentiate between the optic nerve and the ICA, which is just causing nearby. So CT would not be a good modality to look for a local extension. But however, grossly, we don't really see anything in the supracellular system where the optic chiasm lies. Okay. Subsequently, we had another request from the ophthalmology department to image this patient. That was way back in July 2020, where the patient had a sudden onset of right sensory neural hearing loss. So it was a CP angle protocol that was done. There was no indication with regards to the vision at this juncture. So in this scan, we incidentally saw that there is an abnormality that involves the pre-chiasmatic optic nerve. This is the optic chiasm, and then you can see that the pre-chiasmatic optic nerve is thickened and enhancing. This is the coronal image, which is showing the optic chiasm. And more anteriorly, we can see, if you compare the right and the left, that the right optic nerve is thickened and it is enhancing. So given that the patient has had history of a metastatic lesion from the orbit, which involves the optic nerves, this could represent an extension or a residual tumor which has extended and involved the optic nerve at this junction. And the last request that we had for this patient was way back in January this year, when the patient had complaint of a visual problem. And, at this juncture, we can see that the mass has further increased in size. The epicenter of the mass itself is in the pre-chiasmatic optic region here. And here, the coronal view, we can see that the optic chiasm is already infiltrated. Even here on the axial scan, we can see that the lesion is already involve the optic chiasm, and there is also extra axial right temporal lesion in this mass, which is a part of the tumor itself. So in summary, in 2019, when the patient had a CT done as part of staging, we saw that there was a right intracorneal lesion, which is centered at the optic nerve with some intracanicular extension. And in MRI 2020, we can see that there is an enhancing pre-chiasmatic optic nerve with thickened and irregular wall. At this point of time, the optic chiasm is normal. And in 2021, we saw that the residual lesion is enlarging, and there is already right temporal extra axial extension. And at this point, the optic chiasm was infiltrated. So what is the role of imaging here? For this patient, it is mainly used for staging and for local extension. For the purpose of staging, CT would be the best modality, because we want to look for any nodal or metastatic deposits from the primary tumor, if there is, and looking for a primary lesion. And for MRI, it would be best to look for local extension, especially in the orbit, where it's a very confined space. So we do need MRI, which can show soft tissue abnormality very nicely. And in this MRI, we can also see, especially the orbit, when assessing the optic nerve, we can see optic nerve, all the parts of the optic nerve, as well as intracranial extension. Okay, that's all from me. Thank you.
Thank you, Prof. Shahizun. We'll probably take questions later if any of the attendees have any questions to the panelists. I will now call upon our oncologist, Dr. Khairia Siddiq, to tell us more on the treatment, the radiotherapy treatment for this patient.
Thank you, Prof. Dr. Nur Shamsia, for inviting me for this CPC conference. Shall I just share my slide now? Can you see my slide?
Yes, Dr. Khairia.
All right. Right. So this case is quite challenging. It's rather rare. Yeah. So I just history. This is 67-year-old Chinese gentleman with underlying of IHD dyslipidemia and known to have right eye blindness since childhood and presented with worsening right eye pain in 2019. And the patient already had right eye administration in October 2019. And the histology come out as metastatic renal cell carcinoma, clear cell variant. Right, in general, we know that renal cell carcinoma has many variants. The commonest is clear cell renal cell carcinoma, and then followed by papillary cell, papillary renal cell, type 1, type 2, chromophore, oncocytoma, and so on and so forth. Right. So management of metastatic renal cell carcinoma usually is palliative. So in renal clear cell, for clear cell renal cell carcinoma, usually we stratified to 3 category group, risk group. Yeah, either is a good risk, intermediate risk, or poor risk. So usually we give for good risk, we will give TKI such as sunitinib or pazopanib. For poor risk, we will give immunotherapy like nivolumab or ipilimumab. So how about non-clear cell? So non-clear cell like papillary chromophore and all that, usually we don't have enough data to support we don't have enough data to support the indication, but usually we will give sunitinib or pazopanib, the TKIs. So commonly for renal cell, it metastasizes to the lungs. Yeah, most of the time we see that patients have lung metastasis, and then followed by bone metastasis. And some patients might have liver metastasis, about 20% of the case, and very few patients has metastasis to other organs. So there are not many cases that has metastasis to the eye, to the orbit. Yeah, from my reading, there is only about a handful of cases of right eye metastasis to the eye metastasis. So actually, not many patients with renal cell metastasis to the orbit, particularly. So the dilemma in this case is because we don't have systemic disease. We don't have visceral disease in this case. There is no evidence of renal cell. The primary is not seen in this case. Whether we should give what so-called, whether to treat or not, and what the modality. So basically, we had a discussion, lengthy discussion in our department. So I've discussed this case with my colleagues and my boss, Professor Fuad. So he suggested that since this is localized disease, it's only confined in the orbit and the surgery was done, so we decided to give adjuvant radiotherapy in this case. So why do we decide for adjuvant radiotherapy in this case? This is because patient has no disease as well. he has localized metastatic disease. He just has disease in the eye. And we only has one chance to optimize and maximize the control. As you can see that this patient has only disease in the right eye. And there is no evidence of systemic therapy, as there is no evidence of systemic therapy in this case, because we know that the systemic treatment, such as the TKI or immunotherapy, we only give for those who had visceral disease. And usually there is no indication for adjuvant treatment in renal cell carcinoma. So let's say patient has, primary renal cell carcinoma, surgery was done. So usually we only follow up this case, do the CT scan, and no adjuvant treatment given until there is evidence of metastatic disease. And if we have metastatic disease also, we don't always jump to systemic treatment unless patient has heavy burden disease. For example, let's say patient has renal cell carcinoma that metastasizes to the lungs. And then let's say small lesions in the lung and patient is asymptomatic and in good risk category. So we don't jump to systemic treatment. We will wait and see, do the serious CT scan, and once patient has disease progressions or patient symptomatic, then only we start with systemic treatment. And we know that the TKI, tyrosine kinase inhibitor, does not cross the blood-brain barrier. And you must remember that any side effect, any treatment comes with side effect. So we decide to give radiotherapy to the right orbit. So basically our target is to the surgical bed. We give radical dose up to 50 gray in 35 fractions in 5 weeks. So basically when we give radiotherapy, we give daily, Monday to Friday, consecutively. And we give 3D conformal technique and using 6 MV energy. So this is how we treat the case. This is the is the isodose line of 95% isodose. So we give one beam from the anterior and one beam from the lateral, and we tilt a bit to avoid hitting the contralateral eye. Unfortunately, after a year, patient complained, I think less than a year, patient complained of worsening left eye visions. And the MRI shows enhancing mass in the right optic apparatus involving the optic chiasm, with focal mass effect suggestive of local recurrence. And the CT scan shows there is no systemic disease. And the case was discussed in MDT, involving the oncologist, neurosurgeon, and the radiologist. So we have lengthy discussion about this case. So there are a few options for this patient. Either we go ahead with surgery, which is confer high risk, and followed KIV followed by gamma knife, see how much we can debug the more re-irradiation with normal 3D radiation therapy. So some of you might ask, why don't you give a systemic treatment at this point? So as I told you, most drugs did not cross the brain, did not cross the blood-brain barrier. So the pazopanib, for example, has no evidence that it can be used in renal cell with brain metastasis. Same thing like nivolumab, the monoclonal antibody, it also does not cross the blood-brain barrier. So patient was admitted and scheduled for surgery. For some reason, the surgery was postponed up to 4 times. So we come and re-counsel the patients about the options of the treatment. And patient also was quite nervous at that time, and he will also call the high risk that carries with the morbidity that followed by the surgery. So patient decided for re-irradiations. So in re-irradiation, there are a few things that we need to look at. First is what is the dose that was given at the first treatment. So in this case, we already give up to 50 gray. So the challenge of giving re-irradiation in the brain, especially, we have to look after the all the organ at risk. We don't want to exceed the tolerance of each of the organ at risk. So in this case, we decided to give 30 gray in 15 fractions for 3 weeks. So at this time around, as you can see, the one that I outlined in blue is the gross disease. And then we give a little bit of margin for the microscopic and the PTV. So in this case, we give 3 field, 3D technique, and using 6 MV energy. So in conclusion, we know that metastatic renal cell carcinoma to orbit is very rare. So the challenge is we're not quite sure what to do. We don't have the standard treatment to guide us what were the best modality that we can offer to the patient. And it's very important to ascertain the diagnosis. So it's very important to discuss such cases like this in MDTs. And I would like to highlight the importance of counseling regarding the treatment option. Patient has the right to know about what are the treatment options and what are the risks and the benefit of each treatment options. Basically, even though we don't have a proper guideline for this, but we can apply the same basic principle. For localized disease in the brain or orbit, usually we treat with local treatment, either surgery or radiation therapy. This is what we already offered to patients. And as already highlighted just now, there is no evidence of systemic treatment if there is no systemic disease. And I would like to also highlight the importance of holistic care. So, and it is especially important in oncology, managing the oncology patient, especially in stage 4 cases, because we know that we cannot cure the disease. At least we can treat the disease, and patient has the right to know what are the risk and benefit of each options. And then we also would need to explore about patient's background. For example, like this patient, he is 67-year-old gentleman from I think from Temerloh. He is a hawker. He is not very well off, and the treatment is some expenses. Okay, let's say we want to offer TKIs or any systemic treatment. We need to properly counsel the patients about the uncertain benefit. But this treatment comes with it's quite costly. For example, like TKI, it costs about 6K, and immunotherapy costs more than 10K. And we have to continue the treatment, forever until disease progression. So this is something that we need to explain to the patient, make sure they understand. Then I end my presentation. Thank you.
Thank you, Dr. Khairia, for making us understand about something very complex to me. Radiotherapy is not very easy to understand. So thank you. Now I would like to call upon Associate Professor Dr. Farizal to discuss with us on the neurosurgical part of the management.
Thank you very much, Dr. Shamsia. First of all, I would like to extend my appreciation to the ophthalmology department for inviting me to participate in today's CPC. Let me begin telling the timeline of the event involving this patient. Basically, we received the referral at the end of January when patient been admitted for MRI. So straight away, we went to see the patient while in the patient, and we reviewed the MRI with the patient, and also we discussed at length regarding the treatment options with the patient and also with the family member. At that time, what actually we stressed to the patient, we gave the option of surgery and followed by radiotherapy because the patient during that time still have vision on the left eye. But a patient undecided and want to think about it, straight away we refer to the oncology to come and discuss with the patient regarding the options of radiotherapy. And then after that, I think patient discharged. And then we had an MDT meeting, as Dr. Carrie mentioned just now, involving the oncologists and other neurosurgeons, and also neuroradiologists. During that meeting, we decided, or we came to the consensus that because the patient Karnofsky score is very good, at least 80 above. So we decided that this patient may benefit from tumor debulking and followed by the adjunct radiotherapy. So that's what we after the MDT meeting, we straight contacted the patient, and because during this COVID time, so we have to admit patient. We don't have the exact date basically, so we just admit the patient into the ward in planning of to do under surgery under the emergency list. During the admission, which is on the 1st of March, however, we noted that the patient already had no perception to the light on the left eye. And then we repeated the MRI. Not I think Prof. Shahizen didn't discuss this one because normally this MRI was done for IGS sequence in order for us to help us during the surgery. During this, in the repeated MRI, it showed that the tumor increased in size and infiltrated further the chiasma and also encasing the ICAs, both ICA. So in view of this new sign, which is the vision already no perception to light, and the tumor already increased further and encasing the ICAs, and although infiltrated the chiasm, and we know that by tumor debulking, we're not going to bring back the vision, or we're going to save the vision. So we recounsel the patient. Fair enough, as Dr. Karya mentioned earlier, actually we still, even though with this kind of finding, we put the patient under emergency for further surgery, but for 4 consecutive days, we did not manage to slot the patient in because there's no OT time, or sometimes, there's no ICU bed as well. So at the end, as Dr. Karya mentioned, that patient became anxious and undecided for the surgery. Family member become quite apprehensive why the surgery is not be done. And then we recounsel the patient. And then in view of the high risk of the surgery and the benefits, the way between the benefits, then we decided that this patient, we decided not to go ahead with the surgery. And then I refer back this patient to Dr. Karya for further management. And as she mentioned, that patient underwent radiotherapy. So why we recounsel the patient? As I mentioned, when patient came in on the 1st March, the signs are worsened. There's no perception light already. And then the tumor increased in size, casing both ICAs and optic chiasm not visualized, which is infiltrated already. So by doing the surgery, it's not going to save the live vision. And also with the tumor encasing both ICAs and also the cavernous sinus, the morbidity and the mortality is definitely higher. So increase the risk of surgery and technically challenged. So in view of this, we discussed with the family member and the patient, and also with the oncologist. At the end, we came to the decision not to proceed with the surgery and just go ahead with the adjuvant therapy, which is radiotherapy. As we all know that brain metastases carry very poor prognosis if left untreated. The median survival for this patient is about 6 months, involving with treated or untreated. The most common, the brain metastasis, basically the most common intracranial tumors, which is about 80%. The incidence of the brain metastasis increase due to greater use of MRI and the MRI spectroscopy, also increase the survival of the patient with the cancers. because of the increase in terms of systemic therapy, and also the availability of the radiotherapies, different kind of radiotherapy. So, but however, the optimal treatment for brain metastasis remain controversial. Basically, the aims are to maximize the disease control and minimize the toxicity. And the most important thing is to improve the quality of life, because we know their life expectancy is not very long. So as I mentioned just now, median survival is about 6 months. So people may argue, what's the point? We prolong the life of the patient by doing the surgery, but the quality of life after the surgery is not there. This patient, he, apart from both the blind eyes, he's still very well as we know that there's no systemic disease, so he's very well. His ADL's independence apart from the vision. So he has no sign and symptom of increased ICP, for example, headaches or hemiparesis or other systemic symptoms. So the most important thing about this patient is to prolong if not improve. Of course, we cannot improve further the quality of life because the vision is already gone. But at least if we can maintain whatever the patient has now, it will be very appreciated with the patient by the patient. So this is the most important thing to think about when we're thinking about treating patient with the brain mets. Sorry. So what are the prognostic factors when we when we're thinking about the brain metastasis when we want to treat them? First of all, is as I mentioned, the Karnofsky performance score is from 10 to 100. 100 is the best, and then 10 is the worst. So at least if the patient have a score 70 and above, that's a good factor for the to treat patient with the brain metastasis. Age, of course, another important factor. Age, the less than 60 carry higher chances for survival. Extracranial metastasis. Okay, for example, if the patient presented whether they have a mass to the liver or the lungs, which is, of course, this one carry grave prognosis. For this patient, as we discussed just now, there's no extracranial metastasis. So he has a good prognosis in terms of the treatment of brain metastasis. And primary disease also very, very important. For this patient, we know that he doesn't have actually the renal cell carcinoma. So there's basically the primary disease status for this patient is under control. If the patient have a primary disease which not untreatable, for example, is inoperable or not giving adjuvant therapy after the operation, so you may need to think again whether the brain metastasis need to be treated or not. So you need to discuss with the primary team whether are they going all out regarding the primary disease. If they say if they're not going to do surgery, or they say the surgery is not going to help with the primary disease, so to treat brain metastasis per se is not going to make any difference. In addition to this, of course, we have to look at the brain mets itself. First, we have to look at the location of the lesion, whether it's supratentorial or infratentorial. Supratentorial carry good prognosis compared to the infratentorial. When we take it, when I say infratentorial regarding is in the cerebella, also in the brain stems, the number of the lesions. This patient have one only. This patient doesn't have multiple lesion; only have one lesion. So this is a good candidate to treat to offer the surgery. If the patient have 3 lesions, at least we can still offer surgery to remove all 3 lesions. But if more than 3 lesions, sometimes we have to choose which lesion that give the most symptom. For example, compressing on the brainstem or compressing on the iliac area, for example, speech area. So we may want to decompress or debulking the tumor that gives the most problem, and the others treated with the adjuvant therapy. Size of the lesion, the bigger the tumor, the higher is the risk. Neurocognition, basically the higher mental function of the patient when patient presented, this patient, as I mentioned, is totally well. It's very unfortunate for him to have this tumor brain metastasis and unknown primary carry worse prognosis. What we call it is a less better prognostic compared to the tumor that we know where exactly the primary. The most common HPE is about 60% is adenocarcinoma, but 5 to 10% of them we don't know where exactly the primary. So if we know the primary, the patient will carry higher prognostic factors for the patient. Treatment options. So of course, the first one is conservative. It's not applicable for this patient. This patient is totally well. There's no systemic disease, and then there's no multiple lesions in the brain. So that's why during the MDT, we kind of came to the consensus that we need to treat this patient optimally. So this the thing is, we were thinking whether to give radiotherapy straight away or to go for the tumor debulking. But because, as I mentioned, in order to save the vision on the left eye, we need to go and debulk the tumor in order to make the radiotherapy increase the chances to work and reduce the dose, so can save the optic apparatus on the left eye. So that's why we came to the conclusion to the consensus for the surgery at the beginning when we had a NDT meeting sometimes mid-February. So and then the second option is this: what we opted with surgery followed by radiotherapy. The third one, we can straight away went for radiotherapy, which is either whole brain radiotherapy, which is treats not just the cancer that can be seen on the scans, what we call gross disease, but also the smaller sites of cancer that we will not see or visible on the scan, which is called subclinical. Or we can offer IMRT, which is intensity modulated radiotherapy, whereby we deliver higher doses to gross disease and lower doses to the rest of the brain that may contain subclinical disease. And then the fourth option we were discussing was stereotactic radiosurgery. This is the best indication. I mean, if we're talking about the brain metastasis, this is the best indication for SRS. In our center, we have a gamma knife, which is the latest in the market. But because at that time, during the discussion in BNDT meeting, the left vision still viable. So by giving the gamma knife, there is high risk that the patient may lose the vision. And then the second reason also because of the tumor size is greater than 3 centimeters. So we decided that it's not for gamma knife. We have to go for the surgery first. So basically this is the option that we can opted for the management of brain metastasis. Unfortunately for this patient, because of the tumor grows so fast from the scan when the patient was referred to us was done at the end of January, and then when he came into 1st March, the vision already like no perception to light. So as Dr. Karya mentioned just now, we had another counseling with the family members, and then at the end we opted for the radiotherapy and straight away. I end my presentation with this famous saying: good surgeons know how to operate, better ones know when to operate, and the best ones know when not to operate. So we have to think about all these things when we thinking about the treatment, when we're thinking about giving treatment to the patient. That's all. Thank you very much.
Thank you, Prof. Fariza. That is a brave decision to make, to not treat the patient when the indication of no treatment is indicated. I think now we're ready for the HPE discussion. I will now invite Dr. Wan Azura to discuss with us on the HPE results.
Okay, Assalamualaikum again. And thank you, Prof, for inviting me to this CPC. However, I am just invited presenter, but I didn't really prepare, and it's like I thought I was just giving some comments verbally. So actually, I would like, if preferably the pathologist in HUKM will be available, that would be nice. And I just comment on top of her. I was invited on the note that I have a special interest, not a specialty, but a special interest in ocular pathology. I have not much experience, but I have more than others, I suppose, of my colleagues. So I hope you just bear with this presentation, because I will comment on what was the finding from your pathologist, because I think most of the job was done on your side, not on my side, because they just, after finding some abnormal tumor cells in the specimen, they decided to refer to me. So I think Dr. Ehsan, the MO, will just read to me, because when I reported this case, I was in Selayang. Now I'm in Sedang. So I have a bit of difficulty getting the report, but I think Dr. Osmaliza has everything in hand lah. Okay, just read to me the findings and I will comment as we go along. Thank you.
Okay, thank you, Doctor.
Yeah, it's very small, so I cannot read from here. Okay.
Okay, thank you, Doctor. So the first,
you can skip the clinical history. We just go to the macroscopic and microscopic.
All right. Okay. So for the left side, this is the report from the HUKM, and from the right side is when they ask for the second opinion from you, Doctor.
Yeah, that's right.
So on the right side of the report, the microscopic says that the section, this is the HPE from the vitreous body. It shows that the section shows multiple fragment of fibrocalcified tissue with area of blood vessels. Areas of ossification are also present that mix with blood clots and fibrin. Seen attached, and within this tissue are clusters, cords, and papillary-like tumors tissue. So these cells exhibit small to moderate sized nuclei with clear to eosinophilic cytoplasm. So the histochemistry done in Hospital Selayang was PAX8 and RCC both shows positive. And the histochemistry in HUKM, the CD10 and CK7 was positive. CK20 and Melan A was negative. So the final diagnosis was metastatic renal cell carcinoma, clear cell variant.
Okay, Dr. Ehsan can stop here for a moment. So I think from the microscopic picture, you can see the slide above that the cells are rather uniform in size, but their nucleus is small to moderate in size, and the cytoplasm is very prominently clear, and some are eosinophilic. So this already gives us some clue that is a clear cell type of tumor. But in the eye, we also, of course, we need to exclude melanoma, because melanoma is more common than others. But in this case, HUKM pathologist has already done Melan A and so forth to exclude melanoma. So I think that we have done justice to this case. And so when they referred to me, I did PAX8 and RCC, because I think at that moment the pathologist said they do not have these stains in HUKM. So I proceeded to these two stains. Because clear cell, straight away we think about renal cells, okay? Renal cell carcinoma, which is really the clear cell variant. So when we did the PAX8 and the RCC marker, well, to our surprise, it was a positive. So these two markers are rather specific for RCC. So we did not, because RCC, in a way, when we do for even the normal RCC, sometimes that is so obvious from the kidney, they do not really express the RCC. It's very difficult to express. However, in this case, it was rather easy. Okay, so we definitely were already thinking about the renal cell carcinoma, and in PAX8 also is quite specific to urogenital cells, origin of cells. So therefore, these two markers are quite specific for RCC. Okay, so that's why I think I made that diagnosis. However, we also still have to correlate clinically. What you find, where is the primary? But unfortunate for this case, we do not see a primary in the kidneys. Okay, Dr. Ehsan, maybe you can go on. Is there any more?
Okay. Yes. Okay. One more.
So
yes. This is HPE sent after the second surgery, and the cut shows this is the specimen of the right eye. So it is stated here macroscopically. Specimen measures 30. Sorry, hold on. I go to microscopic.
Okay, go to microscopic. I think because you can see the immunohistochemistry stains above. The slides above are the immunohistochemistry stains. Okay, we just read the microscopic for me.
Okay, section shows infiltration of malignant cells arranged in papillary architecture with fibrovascular core. The malignant cells exhibit pleomorphic vesicular nuclear, prominent nucleoli with moderate amount of eosinophilic cytoplasm. Mitosis is seen. The stroma shows desmoplastic reaction and infiltrated by lymphoplasmacytic cells. Areas of fibrosis and hemorrhage are seen. There is no lymphovascular invasion seen. The optic nerve margin is involved by malignant cells, while the rest of the surgical margins are free from malignant cells infiltration. So it is consistent with papillary adenocarcinoma.
Okay, because of the pattern or the papillary structures, they have called it papillary type lah. But also we can say in RCC there is a micropapillary variant with papillary structures lah. We can see there are two types. One is the type 1 and type 2, but I think this is type 1. Looking at these cells, they are like monolayered. You can see that the immunohistochemistry, they stain the nucleus, and they are of single layer. And this is PAX8, right, Dr. Ehsan? PAX8, yeah? Atas tu? PAX8. So PAX8, as I said just now, is quite specific for renal origin. But however, there is also a possibility of thyroid origin. But if you see a papillary in this case, it doesn't really suit the thyroid type of papillary carcinoma, because usually in thyroid papillary carcinoma, we have clearing of nuclei and psammoma bodies, and we have inclusion also in the nuclei, pseudo-inclusion bodies. So in this case, I think we did not see that. So I suppose it's quite fair for the pathologist to say consistent with papillary adenocarcinoma, but I think they did not repeat the RCC. Okay. Next one. Anything else to show?
That's all, doctor.
Okay, that's all. So very unfortunate for this patient, whereby he already had a blind eye. When the patient has a blind eye, I think they are more susceptible to all these tumors. But mostly the common types are melanoma type, yeah? Melanoma type. melanoma type, and also metastatic tumor. Usually we can see the primary, and usually it's breast or RCC. Usually mets to the lungs and the breast, but eye is very rare. But in this patient, if the tumor is in the choroidal area, right? Choroidal is a common area in the eye for mets because it's very vascular, and also unfortunately for the patient, it has sort of extended and increased to the other side, extended and infiltrated to the other side of the eye. So I think it's a very interesting case. But however, it will be more interesting if we can see where the primary is. Now we are just assuming it's from the kidneys, but we don't see the primary there. But it's just the stains that are leading us towards the kidneys. But I suppose there is no, we can't really investigate further because your CT scans, extensive CT scans shows that there's no tumor anywhere else. So most unfortunate for the patient. So I think that's all from me. Thank you.
Thank you so much, Dr. Wan Azura. That is very enlightening on the HPE results. I think now Dr. Osmaliza is ready to wrap up this case. I will now pass over to Dr. Osmaliza.
Assalamualaikum warahmatullahi wabarakatuh. Sekejap ya, saya nak share skrin saya. Okay. Siapa? Ihsan? Can you hear my voice?
Yes, Dr. Liza, loud and clear. Carry on.
Can you see the presentation?
Yes, yes.
Okay. All right. This is the challenges that I, as the last presenter, would like to thank other panelists for contributions of their ideas, as well as management of this patient. This is a challenging cases for me as well as for others in terms of managing the treatment and also to support the psychosocial of this patient, as patient lose the vision and actually he succumb into depression. So as for discussion, there are a few things that we would like to look at. Is actually I would like to highlight the awareness of performing confrontational tests for clinical detection, especially in this case, right? Just to stress upon the importance to the medical students, our young budding doctors. Visual acuity is just not part of it's just not only part of the vision. We also need to assess the visual field via confrontation. And I found that when I asked some of the medical students, they have difficulties of doing to do so, and difficulty of interpreting and documenting the finding. So I'll talk about a bit of the disease itself, and I think, in my opinion, Prof. Farizal and Dr. Hairia have covered extensively the rationale of treatment via radiotherapy and differing tumor debulking surgery, and offering other options for this patient. And not to forget to highlight the psychosocial well-being of our patient and the carers as well. So I'm going to concentrate onto the confrontation test for the sake of our medical student. So this is how do we perform it and how to document the finding. So I have these short videos.
In confrontational field testing, each eye is assessed separately to determine the extent of the peripheral field. Have the patient sit directly across from you, about 1 arm's length away. Make sure you and your patient are sitting so that your eyes are at the same level. This ensures that you and your patient's visual fields are similar. Prior to testing of peripheral fields, ensure that central vision is intact with prior visual acuity testing.
Start by covering your left eye. And if you look here at my nose, is my whole face clear or is there any part that's blurry? It's clear. Good.
We'll now assess the confrontational visual fields with the finger counting method. Ask the patient to cover their left eye and fixate on your nose with their right. At the same time, you as the examiner close your right eye so that the visual field in front of you and the patient is the same. Repeat this process with the other.
Now we'll try the same with the other eye. So cover your right eye with your right. And again, looking at my nose, is any part of my face blurry? Nope. Good. 2, 2, 1, 1. Very good.
You can also perform this examination by asking your patient to identify when they see your finger wiggling.
And looking at my nose, tell me when you see my finger moving. Now. Good. Now. Now. Now.
Certain types of field defects are associated with specific areas of damage along the visual pathway. Here we see the potential visual field defects and their respective damage area.
So that's about the very nice and sweet video on the confrontation. So sorry. To document the findings, yeah. So there are tools that you need to apply when you want to document the findings. First, you need to put yourself into your patient's shoes and record the findings as what they saw. All right. If you look at the on your right side, there is illustration of A, B, and C, a picture of A, B, and C, a diagram. So what we see on A is actually a normal visual field, whereby if you notice on the right side is where the right visual field on the right side is where the right eye is, and the left one's on the left. This is what we have to document it, as I mentioned earlier on, document it as what the patient saw, right? Say B, patient have bitemporal hemianopia. So this is very straightforward. So the temporal side of the right side, the temporal side of visual field, and so because of two sides of bitemporal, so we call it bitemporal. Compared to this C, so we can see that the field defect is on the left side. So straight away we say this is a left hemianopia. Yeah. So this, as for this patient, if you look at the diagram, the Humphrey visual field of this patient, which we did on where he complained of having reduced vision with reduced visual field. So we can straightly say that this patient has left hemianopia with extension of the nasal side, at the inferior nasal side of a visual field defect. Yeah. Right. So we talk about the disease itself. So we come to conclusion that this patient has choroidal metastasis with orbital and intracranial involvement of renal papillary cell carcinoma. So just to highlight the fact that all of ocular metastasis is actually about all metastasis inclusive the whole body is actually 40% of total presentation of renal cell carcinoma, and eye metastases are very rare. So one of the huge report by Dr. Sheffield and his colleague is actually about 2% of 520 cases of uveal metastasis. So most of the cases actually presented after the diagnosis of having renal cell carcinoma. For example, there are few being reported after 5 to 10 years of total nephrectomy. So cases whereby presented before the disease, as illustrated in our case, is very rare. are very rare. So we look onto the cases from 1981 until now. So we have about 2 to 3 cases. So I would understand the dilemma of our neurosurgeon, Prof. Farizal, and our oncologist, Dr. Hairia, in treating this patient with whatever means that they have, because it's very rare. So management of the treatment, as highlighted before, is actually combination of modalities like radiotherapy, immunotherapy, surgical debulking, and so on. So in this patient, we did exenteration due to intractable pain, and at that point, we really want to make sure that we cleared the tumor, as there is no evidence from the HPE as well as the CT scan that it doesn't cross over the intracranial region. So, and he also, the fact that no primary tumor detected is going to be a life a kind of observation and follow up for this patient, in particular looking into the renal cell carcinoma from the urology side and elsewhere. So these are the things that we need to highlight upon. Right. I just need to highlight the part that he actually, we try to refer to psychiatrist for his depression, impending depression, I would say. But he would like to go back to his hometown in Termelo, and we actually wrote a referral letter for him to have his treatment there, and also being familiarized with his surrounding that probably gave him a better quality of life. So the key learning point from this case is actually one, performing confrontation tests should be part of the eye assessment, not just on the visual acuity. So in this patient, eye metastasis of renal cell carcinoma as first presentation is very, very rare. So we are talking about, including this patient, about 3 cases. There's also the need to highlight the psychological needs for our patient and also the carers. And of course, I agree with Prof. Farizal, the need of when to say no. And I really like the quote, Prof. Farizal. I really like the quote that you have displayed before. With that, I pass over to Prof. Sham for the conclusion of the case presentation. Thank you very much.
Thank you, Dr. Osmaliza. I think for the interest of time, we could not take any questions, but any of you, if you have any questions, you can put a comment on the Facebook. I think this is live on Facebook. I think Dr. Liza Dr. Liza, can you just, thank you. In conclusion, I think this is a very interesting case, a very challenging case. It's very sad for the patient, but I think we have done all that we can by all the departments in looking at all aspects of management to this patient. It is a very good learning point to all of us to make sure that we are meticulous and we have addressed all possible queries on the patient's part as well as on our part. With that, I think we can conclude our CPC today. Thank you so much to all the panelists. I think you have done a great job in addressing all the different aspects of this patient. Thank you so much. And thank you everyone for attending the CPC. Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Warahmatullahi wabarakatuh.
Saya akan share Kahoot untuk undergrad. Ada Kahoot untuk undergrad.
Yes, there is a Kahoot session.
Kemudian
Kalau siapa
kita
yang
ada,
boleh.
saya akan share dulu mata CPD lah. Mata CPD untuk doktor. Dan barcode barcode untuk FB Live saja. Untuk Zoom ni tak perlu lagi lah sebab dah dapat link tu. Siapa yang dah share link tak perlu lagi barcode, okey? Barcode ni untuk doktor sahaja.
Cik Bukhari yang MMA apps tu boleh ke atas kasih tak dia punya sebab dia tak semua.
Undergrad untuk Kahoot ni gunakan nombor metrik macam biasa gunakan nombor metrik seperti biasa. Undergrad untuk Kahoot ni gunakan nombor metrik macam biasa gunakan nombor metrik seperti biasa. Undergrad untuk Kahoot ni